Good evening. Today we have a pleasure to have in our studio Dr. Steve Lamberg. Steve Lamberg is not only really great doctor or dentist, but also he's the author of this book, Treat the Cause, Treat the Airway, and also he's inventor of the oral appliance called Lamberg Sleep Well Appliance. Good evening, Steve.
Good evening, Maria. Good evening.
It's so nice to have you here, and we really appreciate your time. And I want to tell story of our relationship to my audience. You know, we know each other. Oh, I know you for many years, and we met. And our first conversation was about temporomandibular joint. And at that time, I was really impressed with the level of knowledge you have in this area. And I want to read a little introduction about you because I want my audience to know you've been practicing general dentistry in Northport, New York for 40 years, and you focus on comprehensive restorative dentistry. And you were always passionate about sleep and wellness. And I know wellness, you did a lot of yoga. I know that personally. And you become a diplomat of American Board of Dental Sleep Medicine in 2011. Like you were a pioneer as a diplomat and serve on a board facility. And, you know, as I mentioned before, you inventor of a Lamberg Sleep Well Appliance, which is FDA cleared appliance for treatment obstructive sleep apnea. And you have patents. You lecture internationally, and you submit your articles to a lot of journals to help dentists integrate dental sleep medicine into the general practice. You also, I didn't mention before, you're founder and serve as a director of Pediatric and Adult Airway Network of New York to provide local platform for dentists, physicians, orofacial myologists, and other related professionals learn and collaborate on treatment patients of all ages. And you have a lot of many other participation in dental sleep medicine world, but today I would like to share with my audience what your book, great book, and I read it from cover to cover, and I find it absolutely fascinating. And Treat the Cause, Treat the Airway was translated in German. And the Quintessence, the other publishing house, pick up the book, and you're going to become internationally, you know, with a lot of languages. So welcome, Steve. And most important thing, I'm going to let you talk, but most important thing, what I want to mention, what you really make a gap between medicine and dentistry smaller with your book and with your lectures, and I appreciate that so much.
Thank you. Thank you. You want to know how this all got started, I guess.
I would like to know how it's all got started. I would like to know your story. I always look for underlying ground.
It was 18 years ago. My friend, Alan, who is a physician in my town, he came to me. He was over for dinner with his wife, actually. And she pulled me aside and said, you have to make an oral appliance for my husband. We have 4 kids and 2 dogs and myself. And he's keeping everybody up at night and the windows are shaking. He's a big, burly guy, and he had very advanced sleep apnea. He was severe. So I didn't know too much about it at the time, but all I knew was that he wanted me to treat his snoring. And now we know that you can't treat snoring unless you've been examined, and we find out from medical legal reasons that you don't have apnea because they usually go together. So Alan, I told Alan, no, I'm not going to make him an appliance. The reason I told him that was because I had recently made 2 appliances for other patients. They were interesting appliances. They were from Great Lakes Orthodontics, big high-rack screw. And it was really a horrible appliance because there was no room for the tongue in the mouth at all. And so it felt like wearing ski boots. So I made 2 of those. The patients came back to me and I said to them, here's your money back. I can't take money from a patient if they say they're not going to wear an appliance. And so I decided I'm not going to do that business anymore. It's a bad model because I pay the lab, of course, and then I don't make any money on the other end. So then he came to me right after I had made 2 of those appliances for snoring, and I said, no. And he offered to pay my lab bills. So I said, okay, you pay the lab bills, I'll make you appliances. And I figure at least I'm not losing money. And after making him 6 different appliances that were out there, he didn't like any of them. And he said to me, and I'm quoting, invent me something. So I had known about the NTI for some time. That's the nociceptive trigeminal inhibition system. And the fact that if you have an anterior point stop in the front, it decreases the muscle activity of the elevator muscles. So I just modified that, and I actually used a deprogrammer instead of the NTI based on the Kois deprogrammer, which is like a Hawley appliance with an anterior stop in the front. And I called John. I asked him if I could modify the Kois deprogrammer and turn that into a mandibular advancement device. He said, sure, go right ahead. You have my blessing. So I fashioned that up in my office, and I made it for my friend Alan because it's really, a minimalist approach to advancing the lower jaw. It doesn't have a lot of bulk to it. It gives a lot of freedom from side to side and open and close. So that was how I got started. And it's funny, what happened was he was so happy, he started sending me patients. And I don't know if you've had the same experience. If you get a lot of patients, but you don't know what you're doing, it's a little scary. So I decided in 2004, I better go take a course. And I opened the journal up just that same day. I was going through this in my head, and there was a course in Salt Lake City. It was the American Academy of Dental Sleep Medicine. And I figured it's June, and there I am in June going to Salt Lake City. They don't have any liquor there, and it's hot. So I'm thinking, what the heck am I doing? And I got out there, and lo and behold, there were 750 people in this conference, and it went for 3 days. And we drank a lot of apple juice and tea, iced tea, because it's really hard to get liquor out there at the time. And over the course of those 3 days, all the light bulbs started going on. I got so excited because I saw people were doing this, and there was more to it than just stopping snoring. There was a medical side of this whole thing. So there was hypoxia, there was fragmented sleep. I met up with Jonathan Parker, who became a mentor of mine. He's up in Minnesota. Then I subsequently traveled up there with my office and took a couple of his courses. And then one thing led to another. My friend who was the physician in town, kept sending me patients, and I started treating them, and I started to learn about the whole process. 2005 is when my little gadget that I made for my friend Alan, I got the patents in 2005, another one 2006. And I found a manufacturer. We did some injection molding for some parts, got Space Maintainers Lab involved because they're a very good laboratory. They're in LA, and they were thrilled to be part of the project. So I would send them the parts, and they would assemble the appliance, and they would market it for me. So it just grew and grew from that really humble beginning, trying to help a good friend of mine. And that's pretty
No,
much the whole beginning of it. And so then eventually the next step of it was, where do you go from there? Well, I figured maybe I kept going every year to this academy meetings. Maybe I should get my boards. I think I can get my boards. And so I applied, I gave them their money, and they gave me a reading list of 300 articles and 3 textbooks. And I said, you're kidding me, right? Yeah, you don't where do I get these articles? They said, that's your problem. So it was very tough at the time. Things have changed. They're a lot more lax now. So I went through the whole process. It took about 6 months, read all the articles, and you have to submit 20 cases first, too. At that time, you had to submit 20 full cases. And I remember going to FedEx. It was 15 pounds of paper, those cases. It was like big, fat notebooks. And they had all these requirements. Once you had that submitted, they allowed you to sit for the exam. I sat for the exam and passed. And then they asked me if I wanted to teach for their board review class, which they didn't have when I took it, but they decided that would be a good idea. So I did that for a couple of years. And then I just got more and more involved in my practice, and I started connecting with the physicians in my area. And there's a lot of interesting medical guys that I developed relationships with, and pulmonary medicine and ENTs. It was very exciting, actually, and very rewarding when you help people when they go from severe and they're on all these medications, and then you get them down to mild or nothing. It's really gratifying. And I think most importantly for people to know is it's not just that. It's also the whole notion of getting the body's nervous system all jacked up, the sympathetic nervous system. It causes a lot of havoc with all of the body's systems, and it causes problems with the teeth and the gums. and there's mouth breathing, and there's so many rabbit holes that we can go down. And I'm trying to be brief and concise and focused just to give you guys an idea of where this all came from. So that's really where things were going. I was kind of interested in developing a screening questionnaire because I didn't really think that you have to give a screening questionnaire. If you look at their medical history, maybe we could decide that why do they have all these NCDs, which are non-communicable diseases. You don't get NCDs from the air. You don't catch them. It's something that you develop by having sympathetic activity being jacked up. So in some of the articles, it always said if you have obstructive sleep apnea, your odds of having reflux, or your odds of depression, or your odds of AFib, or your odds of a number of other medical conditions, it goes up. And I'm thinking, what if you have reflux or AFib or depression? What are the odds that you have obstructive sleep apnea? So I kind of flipped it. I found the statistics, and in the literature, there was evidence on every one of these medical conditions. It wasn't the lead in these articles, but they had it buried in there, and they had statistical analysis, and it's all peer-reviewed journals, major journals. And I started collecting that data, and at a subsequent meeting, it was probably around 2012, maybe 2013, I spoke to Dr. Steve Carsonson, who's the editor of Dental Sleep Practice. And I said, Steve, I got this great idea. Everybody can look at a medical history now, and they can determine the odds of having obstructive sleep apnea instead of launching into all these, esoteric tests to stop bang and all these other tests, which are fine. You can do that also, but it's not necessary. If they're on 16 medications and they see 12 doctors, hello, something's amiss. So he liked the idea, and I kind of got together an article for him. And at the time, there were just 8 categories, 8 areas of medicine, and he published it in Dental Sleep Practice. And I was very excited. I got letters from the president of the academy. They encouraged me to keep going in this direction. And now we have 19 categories representing every area of medicine, every specialty of medicine. I was able to use Google and find out statistics and put the references in this book. And actually, it was a questionnaire that I developed. The questionnaire is in psychology and dentistry and urology, hematology, a couple of questions. It's on one page. And if you ask these questions, it's give them the one-page questionnaire, and they check off a lot of things, then they have a higher risk or higher odds ratio of having obstructive sleep apnea. So that's where it was going. Dr. Kois, who I'm friends with for many years, since I think 1998, I started with Dr. Kois. He liked the questionnaire a lot because it was real simple. And he asked me to write an interpretation key. And he wanted to know, why did I ask these questions? And I said, okay, I can do an interpretation key. I went home and I decided that I can't do an interpretation key because I started writing, explaining why I asked those questions. And then I had to show references and statistics. And it was just going to be more than he really wanted, but it wasn't really enough to be suitable to be an interpretation key for the questionnaire. So therefore, I called him. I said, I can't do it, but I'm going to write a book that's going to be the interpretation key.
Yeah, and this is very successful book. And I want to thank our audience. We appreciate your attention, and please put your question in the chat box, or if you listen to us in a recorded form, you can still put the questions in the comments, and I'm sure Dr. Lamberg would be very happy to answer. But I personally have to thank you, Steve, for the book, because I learned so much, and I start looking at my patients very differently after reading your book. And the chapter I'm most excited about would be dentistry. But first, I want to recite your quote. I really want to put it on my website and make t-shirts and give it to all my patients. Physician, this is the quote, physician will not make you free of the disease. Only you can. So you have to be advocate for your own health. And I want to bring that point up about everybody looking for the magic pill. We so raised up into that culture, what you're going to visit the doctor, and doctor going to give you the prescription. And that prescription going to cure whatever symptoms you have. But
Exactly.
actually, in your book, you said you need to treat the cause. You need to find what really underneath. And I want to say some words about us, dentists, what we actually witnessing, or we see the signs of a lot of disease in the mouth. And you you put together such a great chapter about dentistry in the airway. And a lot of people don't even know what dentists can help with sleep and breathing, or especially sleep and breathing in the same time. How would you define dentistry role in helping to fight this silent killer? And please talk about your experience over 40 years.
Well, we have a unique opportunity because we get to see these patients at least a couple of times a year. And so we can see if the patient's been grinding, if there's reflux, if there's periodontal disease. We have an opportunity to see cracked teeth. We have an opportunity to see narrow palates, large tonsils, big tongues with crenations, and and scalloping. These are things that we get to see, and we have to become like Columbo and look at the crime scene. And the mouth really is a crime scene. And unfortunately, we've been following the medical model for too long. And we look at the mouth and we see a chip or we see decay and we just fix it. But why does this person have decay and that chip? And the next person, they don't even have a toothbrush and they have no decay and they have no chipped teeth and they have no erosions on the back molars. So it becomes really interesting and you become like a little detective. Instead of
You're right. You're
picking
right.
up your piece and drilling, we want to become a detective. And once you do that, you have an opportunity to help that patient become a lot healthier. So if you, just to summarize what that means is, say you go into the mouth and you fix a broken tooth. If you think that that tooth is a result of an airway problem, okay, and say you just fix the tooth. Now the tooth is fixed and they still have an airway problem and their sympathetic nervous system is upregulated all night. And what's going to happen? It's going to take down all the body systems, all the organs in the body are going to eventually be affected. And there will be chronic inflammation, and that's the contributor to most major diseases, the non-communicable diseases. So it's important to understand that dentists for so long have just been treating symptoms as well. It's not just physicians. So now, by way
We
of
are
the book,
guilty as well.
you understand where this is all going. So we have an opportunity now to say, great, let's do this. And I want to add something. I did a lecture recently on not having night guards in your repertoire anymore. Stop making night guards. Because if you make a night guard, what are you doing? You're just basically trying to protect the teeth from being broken. So yeah, sure, you can do that. You can put a night guard in someone's mouth, but then they're still going to, if they have the airway problem, and that's the reason behind it, that's what's causing it, the problem. If you make that night guard, that's going to cause the tongue to recede back into the airway. It's just going to probably make it worse. It would be much better if you think you need to make a night guard to do a sleep study and find out if they do have a sleep apnea problem. Now, they could have some other problem, of course, but chances are it's mandatory to rule out the airway because it's just so common. Does that make sense?
Absolutely makes sense. And I think with, the special philosophy, you're trying to teach, your students, including myself, people you teach your courses, or people who come to the academy, it might even change the view of orthodontics in the society or on child development. I listened to your lecture about how early we have to start look at the airway. And I remember you mentioned about pregnancy. And
That's a whole
it's a
other,
whole chapter in the book I absolutely love. I would like to ask you about this complicated topic in dental sleep medicine, the way how we look at sleep apnea or severity of sleep apnea, about AHI, because that's the mechanism, amount of time we stop, patients stop breathing or airway gets smaller. What do you think about that? If it's defining criteria for sleep apnea, or you have a different opinion about that?
Well, Well, the value of I have a 40-minute lecture on that topic. It's very narrow and very focused, and there's a lot of literature on it. And I think that we can use AHI as long as we consider the fact that you could have two people with the same AHI, but if one person's apneas are longer, then they have more of what we call a hypoxic burden. Their oxygen levels go down further, and that causes more chronic inflammation. So that will contribute more to the breakdown of the body's systems. So we call that the hypoxic load, and the AHI doesn't address that. So sometimes some people feel maybe we should look at the ODI, which is how many times the patient drops down 4%. That would be another handle. I think that we're sort of in the beginning of treatment and diagnosis in this field. And really what would be cool is if we could look at inflammatory markers, because that's what the hypoxic burden is causing. And until we really get our act together with looking IL-6, IL-8, IL-10, the interleukins and CRP, we're going to be just stumbling a little bit in the dark, because it doesn't tell us if they have an apnea hypopnea index of 20. One person with a 20 might have a horrible medical problem because they're very long hypoxic events, and another person might have shorter events that just are long enough to be scored. So it's not the be all and end all. I think stay tuned, because it's not going to be long. I'd say in the next 2 or 3 years, we're going to be able to evaluate more precisely what the impact of the airway problem is. And that goes a little bit deeper than the apnea hypopnea index. And that's this, I can't get more into it without hogging the whole show right now.
Of course, of
let's
course.
use.
But, a lot of wonderful things, you can get from reading your book. But I want to ask you a question about your questionnaire. I know you talk, how you develop the questionnaire. But what I personally look at the questionnaire as a tool for the patients to
Yes.
communicate with medical doctors, because as us medical doctors are different, some of the Picasso, some of the Matisse, so they look at the problem differently. And what would be your recommendation for patients, how to talk to medical doctors about symptoms they experience? I know we cannot dictate the treatment, but as you have to be your best advocate for your health, how would be your recommendation? And this is a very delicate question.
I think it's a great question, and it makes us want to recognize that a questionnaire is not just a questionnaire. Yes, it will give us a risk assessment of the individual, but in addition to that, it's an educational piece, and it's educational for the patient. When you couple the questionnaire with the book, they can understand the pathophysiology and connect the dots, and then they can become their own advocate. So it's for screening, the questionnaire, it's also for education, and it's also for them to become their own advocate. SEA, those three things that a questionnaire is good for. So once they understand the connection, they might go to their doctor and say, "Doctor, blank, whatever, I have all these side effects from this medicine and that medicine. I really want to get off them. Do you think airway could be the problem? Maybe I should just go get a sleep study before I keep taking all this medication. And maybe we can treat the cause instead of just putting our finger in the hole in the dike, which is going to make you feel better in the short term, but in the long term, you're going to have that sympathetic activation and the chronic inflammation. And then the next system is going to go down. And then the next system is going to go down. And it's just going to go on, and you're really not going to be any healthier. You're just going to have a few less symptoms along the way, and who knows the side effects of all the drugs. And the patients I'm talking about, when you get that new patient and they pull a piece of paper out of their pocket and they say, "Here are my drugs." Those are the ones, and you have to type everything into your chart notes, or you have somebody type them all in. You look at that and how does this person get so sick? Well, you have to look at that.
Common story, very common, everyday story. And those drugs, they interact and all of that. And I love the story about high blood pressure medications.
Mm-hmm.
1 and 2 and 3, and no sleep study done.
Yeah, drug-resistant hypertension. That's 100%. That person is going to have some airway problem. Refractory hypertension. Yes, and AFib is a big one too. So much AFib today. So speak to your cardiologist. I would say if you're a dentist out there, share the questionnaire or share the book with the physicians in your area to get a dialogue going, because they'll enjoy it. There's going to be stuff in there they may have heard of, but there's references and a very simple explanation of how everything is related. Also, it's good to give the questionnaire out to all your patients. Leave it in the waiting room, a whole stack of them, because they might not have all those problems. They might be healthy, but they might have an aunt or an uncle or a neighbor, or they might have some kids they know or their own kids who have problems. And once they start looking at that questionnaire, they can become prophets and help you find other patients that need your help.
No, this is great. I really love your chapter on a pediatric, on that process of development with the tongue. Do you want to talk a little bit about the role of the tongue in a facial development?
Well,
In a
I'll talk
short way.
in a short way. The tongue is very important in developing the upper jaw, the maxilla, and then the face grows down and forward. But we know that if you can't breathe through your nose, we know that you're going to be mouth breathing. And when that happens, the tongue posture drops and the upper jaw gets very narrow and the lower jaw just goes down and doesn't grow forward so much. So we have an understanding now that can cause nasal obstruction, which is behind all of this, can cause people to have obstructive sleep apnea when they're adults later on in life because of their craniofacial structures, the size of their jaws, and the fact that their tongue can't fit up in their mouth. So the tongue has to go somewhere. So it goes back into the airway and blocks it. So we have to be cognizant of that. A lot of that has to do with the way we feed our children today. Breastfeeding is the best. Should be a year and a half at least. But today we don't do that so much, and we give them pacifiers, and that's a skinny little thing, and it blocks the tongue from getting up where it should be. And the tongue is a scaffold for the upper arch, which we need to develop. And the whole face is different. You've probably all seen those little kids, so not so little, 7, 8-year-olds, and they have like no jaw. It's all the way back, and it's so sad
And they
because
have usually black
Venus,
circles.
the Venus pooling, yeah, and it's really sad, but we know a lot now about this, so there's no excuse now when we see it. Yeah, I have to control myself in the supermarket. Sometimes I see some of this. It's a parent walking with a kid, and they have what you just described as the Venus pooling, and they have their jaws back, and I mean they're having these growth spurts at 7, 8, 9, 10, 11, 12. And if you miss it, then it becomes very complicated to restore the craniofacial structure. Yes, it can be done. The palates can be split, divided, spread. Maxillomandibular surgeries can be done, but it's complicated and it's not without any risk at all. So it's always better. Prevention is always better in every
Of
field, right?
course, of course. That's why this book is so important for the parents to read. And before, I really appreciate all your knowledge, Steve. I learned so much, and today, and when I was reading your book, and every time we meet, thank you very much. But we appreciate all our audience and people who listen to us and gonna listen in the recorded stage. I would like to ask you the practical advice. If you can give us the practical tip for good night's sleep. I know you described them so well in your book, and some of them I didn't even know, like using the sauna before you go to bed. But if you can give us the broad strokes of a good things you can do to have a sound, silent sleep.
It's a long list, but I think the important things are most people do much better on their side and not on their back. And when you're on your back, the tongue falls back by gravity, and that usually blocks the airway somewhat. If you're nasally obstructed, take a hot shower and make sure you clean out your nose. The idea behind that is we would like you to sleep with your lips together all night long. And we give out tape, mouth tape, and we have people do that. And as a matter of fact, when people breathe through their nose, it actually releases a chemical called nitric oxide, and that chemical is a decongestant. It's antimicrobial. It helps with the oxygen exchange in the lungs. It helps decongest the whole nose. So if you breathe through your nose, you'll find out that it'll be easier to breathe through your nose. It will help decongest it. So those are just a couple of things. There's a long list in the book. There's a whole chapter on tips and tricks for hygiene, for sleep hygiene, it's called.
Yeah, no, they were really great. Like, I find this book, from practical point of view and from philosophical point of view, really, wonderful. And we appreciate your time, Steve, so much. And I hope I'm going to put a name of your book for my audience, and a lot of people can get healthier from getting this knowledge and looking differently.
Thank you. Thank you. If someone is interested in taking more courses on this, I'm teaching a mini residency program in Jupiter, Florida with Michael Gelb, and we're doing that not next weekend, but the following weekend, the last weekend, Friday, Saturday, in this month, in July. And there's 3 more weekends in September and October and November. So if someone's interested in that, and it's very small classes, and if there's a dentist out there and you want to start doing this, the most important thing is you have to learn how to bill for it, because it's medical, and it's a medical billing company. And Michael and I are going to be working with them, and we're basically teaching all the basics, and then they will be teaching the medical billing. And I think it's a great opportunity to get exposure to all this stuff. And go to the American Academy of Dental Sleep Medicine website, sign up. You missed the meeting this year. It was down in Texas, but you can go. Maybe it wasn't down in Dallas, but maybe next year in June. It's usually June. You can go next year. And right before that, there's always a meeting in New York if you're from the area and you're in any of the specialties that relate to airway problems. PANNY is a very good organization. We have a website, PAANNY.org. And on that is a lot of information. We have articles posted by all the different specialties there, and we have blogs and information about upcoming meetings. And this I could go on, but
yeah, no, it's great. I really enjoy PANNY meetings, always. But we can put the practical tips from you, and we put information about the course with Dr. Gelb, as well as information about PANNY under our post, and people can just direct themselves to the website and learn. And again, thank you very much, Steve. I'm looking forward to our conversation in the future.
Thank you. Thank you, honey. Thank you. Have a great night.